Opinions, options, answers. Voice America Health and Wellness.
Welcome to Psychiatry, Ask the Expert, hosted by Dr. Neil Kaye. All comments, views, and opinions expressed are solely those of the host, guests, and callers. Dr. Kaye will not diagnose or treat callers. The information provided is informational in nature. In the next hour, Dr. Kaye explores the inner workings of the brain and mind. Grab a pen and paper and sit back. Here is your host, Dr. Neil Kaye.
Good evening. Dr. Neil Kaye here with my co-host Jay Birch, and we want to welcome you all to the show today.
How's everybody this evening? Neil, how are you?
Had a good week so far, Jay. Each week on Psychiatry Ask the Expert, we focus on a specific topic in psychiatry. We talk about the disease or illness itself, common symptoms and the presentation, and, of course, treatment options with a focus on psychopharmacology, meaning the medication treatments. We talk about potential risks and benefits, side effects, dosing, and when and how to use the best medications. Tonight, Jay and I are going to be talking about post-traumatic stress disorder, often called by its initials PTSD. Listeners are invited to call in with questions at any time. Call-in number tonight, 866-472-5792. Before we get into the discussion on PTSD tonight, I want to go to the On Our Radar segment. Jay, what's been on your radar this week?
Well, Neil, I've got a couple things. The first one is from an article in the recent issue of the Archives of General Psychiatry. I guess you could call it an article on the outcome of income in the treatment of depression. And what this article discusses is a study that was recently conducted at the University of Pittsburgh, where they looked at 278 patients, all of whom were over 59 years old, and they were all receiving currently antidepressant treatment as well as psychotherapy for their depression. And after controlling for a number of different factors, what the researchers found was that people of middle income, and these are folks who had an income between $25,000 and $50,000 a year, they had a significantly greater chance to respond to treatment than were their lower income counterparts. Now, in the high income group, now these are people of greater than $50,000 per year income, they were only slightly more likely to respond to treatment than were the middle income folks. Of interest also is the fact that in the low income group, they had a 2 times higher likelihood of suicide as in the higher income group. So it would appear that poverty carries with it an extra burden of depression.
I read that study, Jay, and I'm not surprised at all by the findings. I think that it's pretty clear financial stress is a major stress for people today, and that you need to be able to make ends meet and meet your basic needs for housing and clothing and food and things like that. And absent that ability, the likelihood that you're going to get depressed or that medications won't work well enough because of the added burden of the external financial stress is pretty obvious. I think you then see sort of a threshold effect, meaning that once you are earning enough to cover the basics, the difference between that and the upper income is not as great, so that money alone won't cure your depression, but you have to have enough of it in order to not worry about basic survival in order to move forward.
So perhaps money could buy you happiness?
Well, it at least can help you be less depressed, but only to a certain extent.
Okay. All right. You know, I've got a second article here, and this comes from last Friday's Washington Post. It actually ties into tonight's topic of post-traumatic stress disorder. And as the Washington Post reported last Friday, more than 1/3 of the soldiers and Marines who have served in Iraq later sought help for mental health problems. Now, this is of interest because this 1/3 number is significantly higher than has been reported before. As a matter of fact, it's significantly higher than the numbers from the troops coming out of Afghanistan or Bosnia. And it's felt that the nature of the combat in Iraq has to do with this high number. By that I mean, as you know, Neil, the traditional definition of post-traumatic stress disorder includes actual witnessing a life-threatening event. What's true in the case of these veterans from Iraq is that there doesn't seem to be a safe zone. There is no demarcation of what's combat zone and what's safe area, whereas in other more routine, if you will, combat areas, there's the combat zone, and then there was always a place where soldiers could go and rest and recuperate and then go back to the war. Well, in Iraq, there isn't a place like that because you're just as likely to be attacked if you're in your barracks or if you're out patrolling the streets somewhere. So this raises a number of issues. The most important issue is eventually these people, these returning veterans, are going to need treatment. They're going to need help. And it's disturbing that the report also cites that two-thirds of these people are not seeking medical attention, not seeking mental health professionals. Of course, the other and perhaps less important issue that it raises is truly what is post-traumatic stress disorder, and may the definition have to be redefined.
Jay, lots of great things in that article, and I have a feeling we're going to refer back to that throughout our discussion tonight. The definition of PTSD and what constitutes a significant traumatic event does, in fact, keep changing over time, both in the legal world, in the medical field, in the psychology world, and so that is in flux. We'll be talking about that in depth tonight. In addition, it points out the important need for treatment, and that a lot of people aren't getting it because of bravado or shame to admit that they're having a problem and that they'll be perceived as being weak in some way. Yes, this war is much different. Of course, each war has had its own intricacies, but the effect of essentially guerrilla warfare and constant prolonged stress and exposure first came out in the Vietnam War and has only intensified in the Iraqi conflict. One of the problems we're also seeing in this is that the VA system has not really been prepared to deal with this huge number of new vets coming back. They're younger than we've seen in the past. There's a much higher rate of psychological trauma, and frankly, the VA budget wasn't planned and funded to deliver the psychological, psychiatric, mental health needs for this many young returning vets for a prolonged period of time. This is going to be an ongoing story that lots of chapters ahead on this one. It's a big, big issue.
Neil, I've got one more, and this is on my personal radar screen, and I don't know if our audience listening is aware, but we're located here in your office in Wilmington, Delaware, and a very dear friend of ours, both personally and in the medical community here in Wilmington, passed away this weekend. Dr. William Holloway was an expert, a specialist in infectious disease, but more importantly, Dr. Holloway was not just a prominent, well-liked, well-regarded physician here in Wilmington, but he was an infectious disease specialist of national and international renown. And the world of medicine and the world in general will be a lesser place without Dr. William Holloway.
I absolutely agree. Bill is a friend to both of us, a mentor and a colleague. Our condolences go out to his wife and family and to the whole medical community and the patients who will not have his expertise available. And sometimes the loss is very much like PTSD. Makes people depressed, makes people anxious. And this was a big one, so I agree.
What's on your screen, Neil?
My screen this week, really just one issue that pertains to all of this, and it's some follow-up on the Hurricane Katrina issue. The government has begun demolishing houses that are deemed to be unsafe in the hurricane-battered areas in New Orleans. Obviously, natural disasters, another life-threatening traumatic event that can precipitate post-traumatic stress disorder, and we're going to talk tonight about some of the differences between natural versus man-made disasters and trauma and how they are likely to cause PTSD, our theme for tonight. Callers, again, 866-472-5791, Psychiatry Ask the Expert.
Okay, Neil, let's clear the air here. Let's jump right into it. Why don't you set the record straight for us and the audience listening exactly what is the definition of PTSD, that's post-traumatic stress disorder?
Okay, PTSD is going to require a life-threatening trauma, and we're going to talk about what is really life-threatening, but the book says It needs to be a life-threatening trauma. And then as a direct result of that life-threatening trauma, you have symptoms that would include re-experiencing of this event, what we call autonomic arousal, the fight-or-flight response, and avoidance. That is, you tend to avoid things that remind you of the trauma itself. And so that's what we're looking for, a particular stressor at a significant level of intensity, a cluster of symptoms in response to that, and then, of course, it has to last a certain amount of time. Arbitrarily, the book, if you would, says symptoms have to persist for 1 month or longer in order for it to meet the textbook criteria.
And Neil, the article that was on my radar screen applied specifically to combat veterans and PTSD, and I know that's an easy kind of connection to make. But I've also heard you lecture several times on this topic, and I think it's interesting because people have been fighting wars for years and years and decades and centuries. So was there no PTSD before the 1960s?
Well, actually, PTSD, as we know it today, has always existed, so that throughout history there's been something that we would call PTSD today. In the Civil War, there was an entity called soldier's heart, and soldier's heart was a cardiac disease, or they thought it was a cardiac disease that is really known as PTSD today. In World War I, a lot of our listeners will remember we developed the expression someone could be shell-shocked, and it was thought that the concussive forces of bombs exploding around them somehow sent shockwaves through their bodies and brains and set them up for vulnerability and psychological injury. Then after that, we came into something that was called a gross stress reaction. That later got replaced by what we call today post-traumatic stress disorder. And again, this life-threatening or potentially life-threatening event with the specific symptoms resulting from that.
So post-traumatic stress disorder itself as a definition, as a medical term, has existed really only since the 1960s, and we've really only dealt with it as a mental illness from that time till this. Is that correct?
Well, yeah, as that specific terminology. So the symptoms and the entity has been around since the beginning of time, but the label itself, PTSD, came about much more recently, and actually credit goes to one of my mentors in my early training, Dr. Larry Kolb, who was with the VA system in Albany, New York, past president of the American Psychiatric Association, and he's probably the one who coined this term. We're going to go to break, and after break we'll come back and talk more about PTSD, post-traumatic stress disorder.
Real Life Solutions. Voice America Health and Wellness.
To perform at your maximum potential, you need to have all aspects of your life working properly. On Mind, Brain, and Body, Dr. Michael John Kell will bring you honest, open discussions concerning your physical, mental, and financial health. If you're ready to find purpose and meaning in your life, tune in to Mind, Brain, and Body every Friday at 8 a.m. Pacific. Mind, Brain, and Body on Voice America Health and Wellness. Radio dedicated to your health, wealth, wisdom, and purpose.
Videos de aprendizaje de inglés. Máxima calidad.
Nunca escucharás a alguien vendiendo educación en la calle, pero con programas familiares gratuitos sí puedes obtener la educación que necesitas. Llame al 1-877-326-5481 para información sobre programas gratuitos de educación familiar.
Mira, vengan aquí. Obtengo un mejor vocabulario en inglés garantizado.
El primer paso a una vida mejor. Un mensaje del National Center for Family Literacy y el Ad Council.
Achieve exceptional levels of health and fitness through integrating the very best in fitness, nutrition, and healing. Tune into Total Fitness with fitness, nutrition, and healing coaches Catherine Carrigan and James Williams. Each week, get inspired to exercise, eat and rest in harmony with your body's needs, and take advantage of effective natural healing methods with in-depth cutting-edge information and advice. Get fit, get healthy, get motivated, and get real with Total Fitness, broadcasting every Friday at 7 a.m. on Voice America Health and Wellness.
Are you tired of being tired? Are you sick of sitting around while life passes you by? You can get back on track by tuning in to Voice America Health and Wellness every Monday at 12 p.m. Pacific Time for Attracting Abundance, the Energy of Success with Carol Look. Attracting Abundance is the program that empowers you to finally break through your limiting beliefs and blocks and shows you how to succeed in all areas of your life, from improved financial abundance, health and weight problems, as well as your relationships. Don't wait another week to be joyful. Listen to Attracting Abundance, the Energy of Success with Carol Look this Monday at 12 p.m. Pacific Time right here on Voice America Health and Wellness.
Parents, did you know that high school dropouts make 42% less than graduates? Someone will have to make up that difference, and chances are that will be you. That means paying 42% of their groceries.
Ooh, more candy.
42% of their dentist bills.
No more candy.
Even 42% of their therapy sessions.
It's all my dad's fault.
Save your money. Encourage your kids to stay in school. For help and advice, call 877-FORAKID. A message from the U.S. Army and the Ad Council.
A fresh look at today's health. Voice America Health and Wellness.
Welcome back to Psychiatry, Ask the Expert. If you have a question or comment, dial toll-free at 1-866-369-3742. Now back to the show. Here's Dr. Kaye.
Hi, Dr. Kaye on Psychiatry, Ask the Expert. Actually, call-in number tonight, 866-472-5792. We're talking about post-traumatic stress disorder.
Hey, Neil, now, I started you off with defining post-traumatic stress disorder, PTSD, and you gave a definition. And you teased a little bit because you said everything hinged on kind of the interpretation of life-threatening. You and I talked about, is it life-threatening if someone attempts to hold you up or rob you with a gun that is not loaded? And so why don't you kind of lead us with some discussion of exactly what qualifies as life-threatening?
Okay, again, the book, as we'll say, says that the stressor, the event that triggers this emotional reaction, is supposed to be a trauma, emotional or physical in nature, that would be expected to be extremely traumatic for any individual. So something out of the usual realm of experience. Frequently cited potential stressors include things like combat, natural disasters, assault, rape, fires, poisoning. But I like to talk about what is the normal level of trauma. In other words, simply because something occurs 51% of the time, does that mean that you can't really have PTSD as a result of that? And I think that that's illogical. I mentioned the Hurricane Katrina victims, and, well, everyone in New Orleans experienced Hurricane Katrina. Obviously a life-threatening event, and in fact, many people lost their lives in that event. Some might try to argue that, well, they can't have PTSD because since everyone experienced it, it's not out of the ordinary. Or if you lived in Oklahoma and managed to survive a tornado, well, everybody in Oklahoma has tornadoes, so there is no such thing. Well, that doesn't make sense. In practicality, in reality, if a person legitimately believes that their life and physical well-being are at risk, then most of us out in the field as experts agree that that perception is in fact sufficient. I teased you with the example of being held up but with an empty gun, and so your life couldn't be in danger, but you don't know that because you don't know the gun is empty, and obviously you would respond to the perception of it being life-threatening. There's an issue also about chronic low-level stressors, so things like chronic abuse or harassment in the workplace. Relatively common, unfortunately, no place for it in our workplace, but can a low-level stressor that's chronic be cumulative in nature and build up enough to actually break someone and cause PTSD. And again, I think a lot of people believe this. I also think that September 11th really changed a lot of things. After September 11th, a lot of people who saw the World Trade Centers implode hundreds of times, almost like an endless video loop on TV, developed nightmares and reliving of the event simply because they had been exposed to it via television ad nauseum, and it was not healthy. And we actually had to start instructing patients to turn off the TV and to stop the exposure. They felt threatened even though they weren't there in New York and they were simply watching it. And that may sound unusual to people, but I'm also quite sure we have members of the audience who had this same experience themselves. So the stressor, life-threatening, clearly is a perceptual issue.
A perceptual issue on the part of the person who's experiencing the event.
Exactly.
And some of the events you gave examples of were natural events, the hurricanes, the tornadoes. Now, I understand the perception of life-threatening, but certainly there is some expectation or common knowledge of these natural events as opposed to walking out your door, maybe to your car, and having somebody pull a gun on you and threaten you, like a human-caused traumatic event, just like the World Trade Centers.
Right. Big difference, actually, between man and Mother Nature, as we'll call her. That is, trauma that is induced by man is much more likely to cause PTSD than trauma that comes from natural disasters, natural events. A variety of reasons we believe that this is the case. It's easier to be angry at a specific other person. It's not quite as easy to be angry at either God or Mother Nature in that regard. Some people are cynical and say, well, you can't sue Mother Nature, and the only reason people have PTSD is so that they can go out and sue somebody and make money off of this. What I'd like to point out is that the literature is very clear that even if someone does sue and gets a payment in settlement, their symptoms remain after the check has cleared the bank, and essentially it's not a litigation issue. Litigation does not cause PTSD. It does not treat or cure PTSD. There's some question about retaliation or empowerment that might come through litigation, and litigation is common in people with post-traumatic stress disorder, partly because of how people get injured. Car accidents being very common, assault, trauma being very common. But again, Mother Nature certainly causes PTSD. The other thing about PTSD that happens in the natural phenomena is there tends to be a large number of people who have been through the same event. Hurricane Katrina, another beautiful example again, where you are able to share and re-experience and reprocess what you have gone through with other people. Therefore, it's not as shameful to you, and you get the benefit and support of other people who have had the same experience, and that tends to normalize the experience so you don't feel like an outcast and that you're so different.
I know you think you've probably answered this, but I'm going to push you one more time. On the topic of traumas, can you list some traumas or categorize some traumas that most commonly result in a diagnosis or treatment for post-traumatic stress disorder?
Sure. The most common, without a doubt, in men is going to be combat and auto accidents. In women, assault, rape, sexual abuse would be the most common that we see in that in the women category, and those are really the most common causes for PTSD that we encounter.
How about PTSD in children?
PTSD in children certainly exists. In children, sexual abuse, assault, beatings of some sort, most likely to be the underlying cause. Difference in kids is that when children are young, they don't have the defense mechanisms, they don't have the life experience to process what it is that they have experienced. So in some ways, they're actually more vulnerable to the development of PTSD than, say, adults who have learned to cope better, have more strategies, might have more supports. And also with children, there's a little bit greater likelihood that the people who traumatize you are, in fact, the people who are supposed to protect you, and that makes it extra difficult for them as well.
In general, then, speaking of post-traumatic stress disorder, can you give us some numbers about how often this occurs? How often does it occur maybe in the female population versus the male population? And generally, what's the level of this problem?
Sure. PTSD is the fifth most prevalent psychiatric illness that we know of. So it's actually remarkably common, but really underdiagnosed. If you look at the American population in general, more than half of us, greater than 50%, actually experience a stressor sufficient in severity to cause PTSD. In men, about 60% of us experience PTSD-level stressors, and for women, a little over 50%. Only 20% of people go on to develop PTSD. So most of us will shake off that first assault, if you would, and don't develop PTSD. Overall, about 4% of the population each year develop PTSD. It's actually twice as likely for a woman to develop PTSD than a man. And part of the issue here is not that women are weaker, it's that they are more likely to come in and be diagnosed and to deal with it in an emotional way. The flip side of PTSD in men frequently is alcoholism, and that men will frequently go out and drink or do drugs in a way to bury and hide and mask their emotional feelings rather than come in and be diagnosed or deal with things up front.
Well, Neil, such a high percentage of men and women actually experience these traumas, and yet such a small percentage of them end up with post-traumatic stress disorder. Does this really raise the issue of, are some people just weak?
Well, it certainly raises that issue, and that's one of the things that keeps people from coming in for treatment, is they're afraid of being diagnosed as weak-willed wimps. And so that actually prevents them from coming in. One of the areas we see that as a particular problem involves our rescue workers, police, firemen, paramedics, who are exposed to trauma and life-threatening issues at a very high rate. Police officers, as you know, they get shot at, they may be shot at any time, and yet they need to feel strong and macho, and so they don't want to admit it and come in. And so they actually are less likely to seek treatment, but to internalize it, then to try to deal with it either through, again, alcohol or drugs, or they take their stress out on other people and their families, which can be just as injurious in another way.
Okay, that kind of summarizes the nature of the illness, and when we get back from break, we'll talk about the patient in your office. But I'd like to, again, encourage the people out there listening. While Neil and I are having a great time talking to one another, we certainly encourage you to interrupt us at any time and ask a question if you're so interested. So we'll be right back after the break.
Opinions, options, answers. Voice America Health and Wellness.
Stay mentally, physically, and emotionally fit with Younger Every Day. Hosted by Dr. Bob Payson. Broadcast every Friday at 10 a.m. Pacific Time, 1 p.m. Eastern Time on the Voice America Health and Wellness channel. Younger Every Day will offer you alternative solutions for a variety of health issues, all backed by clinical, scientific, and medical data. Dr. Payson and other expert guests will inform and inspire people of all ages to look and feel better. Younger Every Day. Think clearer, feel strong, grow younger. With Dr. Bob Payson, right here on Voice America Health and Wellness.
Women, do you feel that you're too old to be active, too old to be beautiful, too old to have fun, or too old to be fabulous? Well, if that's what you think, then there's good news for you. You're wrong. Tune in to Voice America every Wednesday at 8 a.m. Pacific Standard Time for Aging Outside the Box. Fabulous Women Over 50 with Shirley Mitchell. Aging Outside the Box is a fabulous, fun program that gives you every reason to feel greater than you ever have. Host Shirley Mitchell and OE Cruiser Small will cover phenomenal topics such as women's issues, health, diet, exercise, nutrition, faith, travel, and many other concerns for women of all ages. Feel young, feel smart, and feel fabulous by tuning in to Aging Outside the Box. Fabulous Women Over 50 with Shirley Mitchell every Wednesday at 8 a.m. Pacific Standard Time, right here on VoiceAmerica.com.
To perform at your maximum potential, you need to have all aspects of your life working properly. On Mind, Brain, and Body, Dr. Michael John Kell will bring you honest, open discussions concerning your physical, mental, and financial health. If you're ready to find purpose and meaning in your life, tune in to Mind, Brain, and Body every Friday at 8 a.m. Pacific. Mind, Brain, and Body on Voice America Health and Wellness. Radio dedicated to your health, wealth, wisdom, and purpose.
Step into a healthier you. Voice America Health and Wellness.
Welcome back to Psychiatry, Ask the Expert. If you have a question or comment, dial toll-free at 1-866-369-3742. Now back to the show. Here's Dr. Kaye.
Psychiatry, Ask the Expert with Dr. Kaye and Jay Birch. We're talking about PTSD tonight.
Neil, let's move forward a little bit in our conversation. When you talked about defining post-traumatic stress disorder, you mentioned 3 specific symptoms or characteristics of a patient experiencing post-traumatic stress. You want to go through those and really tell us a little bit more in detail what they are and what they mean?
Sure. So you have the perceived life-threatening event, and then you have symptoms in 3 categories. Category 1, re-experiencing. That is, it feels like the issue, the stress or the trauma is happening again. This can present in dreams, nightmares, intrusive thoughts, and again, in some people, actually feeling as though it's taking place all over again, something we call reliving. Category 2 is autonomic arousal. And I describe this as the fight or flight kind of response that humans have. This presents with anxiety, insomnia, trouble sleeping, hypervigilance. People always on the lookout. They're overly aware of their environment, believing that if they are just better observers and more vigilant, they'll be able to see things happening and thus protect themselves in advance. Depression, cognitive problems, troubles with sustaining attention, focus, concentration, and memory, and impaired concentration. So autonomic arousal, cluster number 2. And the third cluster, the avoidance cluster. And this includes avoidance of the place where the trauma occurred. An example would be someone's in a car accident, and so they won't drive through that intersection where the accident took place, or things like that. Avoidance of people. That may be disconnectedness with people around you, or sometimes avoiding people who in some way might remind you of the trauma. Avoidance of feelings. So emotional numbing and depression come under avoidance as well. People don't want to develop closeness because they can be hurt in this process, and so they will become numb or rock-like. They try to avoid reminders or links to the trauma. Again, people, places, and things that will trigger a reminder. They may avoid relationships because of loss, and then they can generalize, meaning that they can go from just a specific to a more general avoidance. An example might be a woman who was raped in an elevator. And instead of just avoiding elevators, now all small confined places become dangerous or traumatic. We see it frequently in automobile accidents, where someone's in an accident on a big interstate, but they start to avoid not just cars and interstates, but even smaller roads and back roads, and they can in fact become almost housebound as part of their avoidance, an effort to assure their own safety.
And they have to actually have all 3 of those, or one group, 2 groups?
technically you have to have symptoms in all three categories. Obviously, you don't need each and every symptom, but you need to have symptoms in all three categories to technically make this diagnosis. When I talk about technical diagnoses, in psychiatry we use something called the Diagnostic and Statistical Manual put out by the American Psychiatric Association, and it sets up a list of these exact criteria and the duration, although in a broader sense when it comes to clinically treating these people, you can have limited symptom PTSD, meaning you have the trauma and symptoms from two of the clusters, but not all three. Well, we're still going to treat you as though you have all three because you need the treatment and you're symptomatic.
Let's hold the treatment for a little bit later. I want to take everybody back to our last week's show where we had Dr. Robert Granacher, and he discussed with us traumatic brain injury, and he was really in the field of the physical damage and physical injury to the brain in a trauma. What we're talking about tonight is really the mental and emotional trauma to the brain. And can you, since everybody doesn't have a little physical model of the brain, can you kind of describe what we think happens physically, mentally, or emotionally, neurologically to the brain during a trauma that causes this stress disorder?
Sure. Well, what happens to the brain is that in this traumatic event, there are tremendous electrical chemical discharges in the brain. Essentially, the brain is just overwhelmed, and people who have been in trauma may tell you that they can't really remember everything that took place. Essentially, the brain is overwhelmed with stimuli, and it's doing whatever it can to just sort things out and to get you through this to survive. It's the way we are built, if you would. As a result of that, there can be repressed memories, there can be emotional states that you're just not completely aware of, and part of what we're trying to do is to get that material back out where it belongs. The changes in the visual processing, in the memory processing during PTSD are now being studied through some pretty fancy science techniques involving special electrodes and imaging that let us see this and learn more about it. So there are clear biological changes that take place in our brains during PTSD events and during stress. In fact, there's some emerging technology that may let us actually do images, MRI scans, and the like of the brain of people with PTSD, documenting changes in the size and shape of specific regions of the brain that are behind post-traumatic stress disorder.
And is there a reason to believe that one person's brain reacts differently, but it's the residue that's left from the trauma that results in the post-traumatic stress disorder?
Well, it could be. Obviously, we each come into our life events with our own baggage, with our own strengths and weaknesses. Most of us argue that if you stress almost anyone sufficiently, you can produce PTSD. And so if you look at something like concentration camp survivors, about 75% of them have PTSD. What you want to remember in the concentration camp group is that these were the survivors. These were the strongest of the group. Those who were weaker were, in fact, exterminated in the gas chambers. So 3/4 of the strongest survivors have this, and that tells you that if you stress people enough, you can do that. In natural disasters, again, like Hurricane Katrina, 50 to 75% of people will develop PTSD. And so, again, the level of stressor multiplied, if you would, by the duration, how long you have to endure it, and the intensity of it, that together gives you an idea of how big the stress was, and in turn makes some prediction for how likely anyone in general is to have PTSD from what occurred. But again, some people come into a trauma more prone to develop PTSD than others, and we actually can screen for that in advance.
Let me ask you what might seem to be an impossible question to answer, but you're the expert, so that you get these anyhow. You've got a tremendous variety of traumas available out there in the world. You've got a wide expanse of potential symptoms that result from experiencing these traumas. Is there any way that you can describe the typical way that a patient would present in your office for treatment for post-traumatic stress disorder?
Sure. The clinical presentation differs a little bit in a psychiatric office.
Sure, like that was such an easy question.
No, it's not an easy question, but there is a typical, you gave me a little ouch, you said kind of a typical case. Well, in psychiatry, patients present one way. In primary care, family medicine, they present a little bit differently. But what we see in psychiatry, combination of anxiety and depression overall, guilt, rejection, anger, irritability, panic attacks are common, problems with memory or attention, maybe some problems with impulse control, and coexisting alcohol or substance abuse is pretty common. Partly because people who have drug or alcohol problems are more likely to develop PTSD, but also because a lot of people, as I mentioned earlier, are likely to try to self-medicate for their anxiety and depression with drugs or alcohol. Now, in a general physician's office, presentation tends to be what we call somatic. Somatic is just a big word that means medical or physical in nature. So that patients come in with a combination of GI, gastrointestinal problems, upset stomach, diarrhea, acid reflux, cardiovascular symptoms like palpitation, rapid heartbeat, dizziness, neurological symptoms, which again can be dizziness, tingling, fainting spells, headaches, generalized pain, fatigue, malaise, and musculoskeletal problems. Essentially, the more symptoms a person has that cross more organ systems, so a cardiac symptom, a neurologic symptom, and a gastrointestinal system altogether is more likely to be psychiatric, stress-related, than it is physically, simply because of the way humans are built. So multiple physical complaints really is the most common one. I have to say, overall, reliving, re-experiencing the nightmares, the hypervigilance are real tip-offs in our world.
I mentioned earlier on my radar screen the article from last week's Washington Post, and they cited that two-thirds of the veterans who had been screened and showed on a positive test for symptoms of PTSD, that two-thirds of those people were not going to seek medical attention. So how long is it between the actual time of trauma and the average time to which a patient may tough it out and eventually end up seeking care?
Well, it's really quite individual in that area. Young kids, if they are traumatized, frequently don't know how to ask for help or get anything, or, again, they are the victims of the people who are supposed to protect them, so they don't have anybody to go to. So they're more likely to repress it and to have a very delayed onset. And so it's not unusual for us to see a girl who was an incest victim, say, between ages 1 and 3, and now in adulthood is finally coming forward with unusual symptoms that eventually are traced back to this rape or incest. Adults, they don't tend to repress on the whole because they're aware of what's going on, and especially the soldiers don't repress. They remember exactly what they were doing, what was taking place in almost all of the circumstances. The question is, when will their symptoms be bad enough that they just can't tolerate them and come in? In the soldiers, what happens a lot of times is someone else forces them to get treatment. Okay. A spouse, a significant other simply says, I can't stand you screaming in the middle of the night in your nightmares and dreams, or you're fighting me, trying to choke me, doing things to me during your sleep, essentially acting out on the nightmares, and I'm afraid of you, and you either are going to go get treatment and you're going to go see the doctor, or our relationship is going to end. And so frequently in that category, someone else will force the issue. Occasionally, one of these guys will talk to a colleague, another vet, who will say, gee, I'm having the same sorts of things, and they might together respond to an advertisement put out by the VA or some support group, and that might be helpful as well. We're going to go to break. We'll be back after the break.
Helping you make informed decisions for your life. This is Voice America Health and Wellness.
Hey, how you doing? Educational videos, top quality, right here.
You'll never hear anyone selling education on the street. But with free family learning programs, you can get the education you need. Call 1-877-FAMLIT1 for information on free learning programs. 1-877-FAMLIT1.
Check it out, check it out. Win your GED right here, guaranteed, ma. Come on, check it out.
Free family learning programs from the National Center for Family Literacy. Brought to you by the National Center for Family Literacy and the Ad Council.
When you combine energy secrets from ancient China and the latest breakthroughs in medicinal science, you get power healing with Dr. Shah. Heard every Friday at 5 p.m. Pacific Time on Voice America Health and Wellness. Each week, Dr. Shah will bring you another step closer to the expanding world of body-space medicine. You will quickly learn and appreciate how power healing is a perfect alternative to hospitals and expensive drugs. Take a step beyond modern medicine every Friday at 5 p.m. Pacific Time with Dr. Shah on Power Healing, right here on Voice America Health and Wellness.
Growing Up in America explores the challenges, risks, benefits, and differences this generation of children face each day. Hosted by veteran pediatric emergency physician and father of 4, Dr. Charles Nzika, this show is for parents, teens, and children. It crosses each generation. By exploring the unique aspects of matriculation within this current generation, we hope to find answers and ways of optimizing this experience for today's generation. Growing Up in America with Dr. Charles Nzika broadcasts each Tuesday at 2 p.m. Pacific, 5 p.m. Eastern on the Voice America Health and Wellness channel.
Opinions, options, answers. Voice America Health and Wellness.
Welcome back to Psychiatry, Ask the Expert. If you have a question or comment, dial toll-free at 1-866-369-3742. Now back to the show. Here's Dr. Kaye.
Actually, it's not Dr. Kaye. It's Jay Birch. How are you doing out there, audience? Just to recap, we're here this evening talking about PTSD, and what we've discussed so far is a definition and clinical examples of PTSD. We've gotten the patient in to see Dr. Kaye, and so now we're going to present Dr. Kaye with some discussion on treatment options. So, Neil, talk about treatment options that are effective in dealing with PTSD.
Okay, 2 approaches simply to PTSD. First, we have the talking ones, and then we're going to talk about the medication ones. In the talking area, there are a variety of talking treatment strategies that are very helpful, very important, and as usual, I'm going to encourage a combination of talking and medication. Cognitive behavioral therapy and stress inoculation therapy are well known to be helpful, along with prolonged exposure therapy when it's done properly. Biofeedback and relaxation and
Whoa. Can you help us out here with stress inoculation? What's going to happen?
Sure. There are some specific techniques that have been developed by the psychologists to help deal with particular traumatic issues. And the theory here is that when you are traumatized, your brain is, again, overwhelmed by all of the stimuli, and we need to help you reprocess it. And if you can reprocess the material and sort it out, you will be able to make sense of it and thus not have it affect you. At the same time, you have one trial learning, so that when you're stressed to the point of life or death, you learn in that one instant what you need to do to survive and what's dangerous. The problem is you might have your alarms going off at the wrong time in the future, and similar situations might not always be life-threatening. So we need to get you to be able to tolerate that stressful event or situation or the stimuli that caused that, but then to teach you to bring down that adrenaline response that you would normally have, so that it doesn't affect you in the same way. And these techniques are what teach you in a learning way to deal with the anxiety side of the PTSD picture. The other course is the medication side, and I want to make sure that we cover that. The reason is that there are medications that have been developed for PTSD, specifically a couple of the serotonin reuptake inhibitors that are usually used in anxiety and depression, and these can be very helpful when they're used properly with good physicians as a real backbone of treatment.
Now, these serotonin reuptake inhibitors, is it all of them or just a couple of them, and is that important that they've been tested and tried in post-traumatic stress disorder?
Well, to me it's important that they've been tested and tried, although some people like to think that all drugs of a class must be the same. That's not really the truth. That is, there are drugs that have shown efficacy for specific disorders, and those are the ones we want to be looking at. The drugs that probably get the best, quote-unquote, press, if you would, in FDA approval, sertraline, which is marketed as Zoloft, paroxetine, which is marketed as Paxil, probably have the best data behind them, different profiles, different side effects, and the research that brought them to market is also different in how it was designed.
Neil, it seems like PTSD is one of those illnesses which is very complicated by the tremendous emotional overload the patient experiences. And we had Dr. Jack Detweiler here with us a few weeks back talking about psychotherapy, and you mentioned psychotherapy as one of the arms of treatment. Is a combination of pharmaceuticals and psychotherapy really the gold standard in PTSD, or can one or the other stand alone and be used singularly?
Well, a lot of times people will try one or the other, and frequently they want to try a non-medication approach first. If you think about PTSD, that it occurs in a time when persons feel completely out of control. The experience of helplessness is part and parcel of PTSD. I remember one of the worst cases of PTSD I ever treated was a fireman who had gotten trapped in the basement of a burning building, and his 911 radio didn't work, and he basically was awake, alive, and conscious and thought that he was going to die as the building above him burnt and the basement flooded with water from the fire hoses, and he could not get any help or rescue. And so the longer you feel helpless, the more profound the PTSD symptoms are going to be. Fortunately, by the way, that case did have a good outcome. He was rescued, but he did develop severe PTSD. So talking therapy, a lot of people want to try because they don't feel that they have the same control with medication. However, for most people, medication with the therapy is really the way to go. And again, there's a tendency sometimes for people to just take minor tranquilizers, Valium, Xanax types of medications. We want to get away from those if we can. It's not the right way to go. They actually can detract from treatment in some people, and there's a risk of abuse with those drugs. Drugs like, again, sertraline, Zoloft, paroxetine, Paxil are shown to have efficacy, not addicting, and when you get them on board, patients' irritability, their obsessing and reliving of the trauma tend to go down, and it makes it much more likely that they can do some of the psychotherapy work that we discussed with Jack when he was our guest.
Okay, before we have to wrap up the show, I'm going to give you the kind of question you hate. It's the multiple choice question or multiple part question. I want you kind of describe for the audience, if you will, when you say treatment has been effective in a post-traumatic stress disorder patient, essentially what does that patient look like that's different from when they walked in? And the last part of the question has to do with, are there some traumas which really don't seem to respond very well to any type of therapy? What's really the response rate overall in post-traumatic stress disorder?
Okay, overall what we talk about for response is about a 50% reduction in the intensity of a patient's symptoms. We have a variety of rating scales that we use for symptoms in patients with PTSD, so we can have you take our pencil and paper test when you come in, and then after treatment a number of months, we would expect to see a 50% reduction in symptoms. That's one way to look at it. I look at functioning and how a person is living. When a patient feels that they can go out again and feel safer, that they have a greater power and control over their environment and their life, well, that's a treatment success, and they say thank you, and they're well aware that they're doing much better. They do not forget, and I want to drive that point home. Success is not forgetting what it is that occurred. It's simply not feeling powerless about it anymore. And so people will never forget that life-threatening experience, but they will learn to go on and to continue to enjoy life, to be able to experience relationships and joy and a full range of emotions again that might have been constricted or restricted by the trauma that they had experienced. Overall, about 30% of people will recover completely from PTSD and have no symptoms. 40% will have persistent but mild symptoms. Only 10% actually remain unchanged or get worse. The healthier you are psychologically before the trauma, the better, and the better the prognosis. It's better if you have good support systems, significant others, married, financial resources, good jobs, things like that.
Okay, that about does it. Why don't you go ahead and summarize tonight's take-home points and list some of the referral organizations that are out there for patient support.
Great. Let's wrap up the take-home points for tonight's topic, PTSD. Anxiety and depression are common responses to trauma. Talking about your experience and your fear is very important to getting better. Don't hide this. Don't bury it. Don't be ashamed. Don't self-medicate for the feelings with drugs or alcohol. Medications, particularly SSRIs and the psychotherapy techniques, together give you the best outcome. If you or someone you know is having any kind of mental illness or emotional problems, please help them find professional help. Give them the support and love that family and friends can do. Talk to your doctor or trusted friends and coworkers to try to get good referrals along with the medical society, psychiatric society, or psychological organizations. Online, get information at psych.org, healthyminds.org, NAMI.org, or NIMH.org. I want to thank our listeners for participating. Next week we have Dr. Lee Cohen from Harvard Medical School, one of the world's authorities on women's mental health issues. It's going to be an exciting conversation. I want to thank everybody. Jay, we'll see you next week.
Good night, Neil.
Thank you for listening to Psychiatry, Ask the Expert. To learn more about Dr. Kaye, visit courtpsychiatrist.com. Tune in next Tuesday for another hour of Psychiatry, Ask the Expert with Dr. Neil Kaye.